Hello everyone, so now we are at the second part of the hematological disease. So first over here we're going to go through a little bit about hemophilia. So there's a few guidelines available, and Malaysia also has its own clinical practice guidelines, which then reflects the higher prevalence of hemophilia in Malaysia as well. So basically there can be one of the two common scenarios. So first is the dad has hemophilia. So because it is at the X chromosome, so if you cross in a way, so if the mom is a non-carrier, the daughters will be carriers. So in another scenario, so whereby the dad is normal but the mom is a carrier, so when the mom contributes the X, so there's 50% of a chance of the son will get hemophilia, whereas there's 50% of the daughter that will be carriers, right? So let's move on. So basically, they need to be tested accordingly, right? They have to be, because there's different types of factors which are available, right? That like what you have already learned in your third year previously when you learn about anticoagulants. So the common ones is actually on factor 8 and also factor 9. So they can actually have to be tested. So if then they have prolonged APTT time or prothrombin time. So from there, then they'll know exactly what happened. So if they may need prophylactis factor infusion as well. So there are some protocols available, which are for factor replacement therapy, right? So you can see that it's actually at quite a high frequency. Actually, like for example, it can be hemophilia A or B, so it can be up to 3 times a week or twice a week. So for the very high dose ones, or it can be at the low dose ones for twice a week. So you can see it's quite intensive one. So there's also non-pharmacological treatment, because obviously there's a very high risk of them to bleed. So if they actually have a cut, so what should they do? So it can be try to have protection, of course, to prevent it, rest, ice therapy, compression, elevation, right? So they can in acute bleeding, so they have to give selective inhibitors, right? Okay, so next, so there are some, besides the factors infusion to them, right? They can also have certain adjunct therapies. So for example, one of it is actually desmopressin. So when I look through it, I also feel a bit like, hey, how is it? Why is this further here? Because you know that this is actually an analog of vasopressin. But they realize that if you give them desmopressin, they actually can boost the blood levels of the factors in mild to moderate hemophilia. So actually it's effective and safe. So it's pretty effective, but things we are not sure what makes it effective, right? So so you can see there's a very long list on the proposed mechanism of action, right? But again, it's just a proposed anyway, right? So we're still not sure exactly which part of the action of the drug actually contributes to it. So it can be in IV or subcutaneous form or intranasal form. So you can see there can be certain side effects as well, right? So IV, so it can cause tachycardia, flushing, and so on. Okay, so next, so then the side effects is antidiuretic activity, which is similar like a high dose of vasopressin. Okay, so another drug which is commonly being used is this tranexamic acid, so which is promotes clot stability. So this is also commonly being used over here. Right, details you can read through over here. And just to bear in mind, people with this disease can also suffer from pain, right? So similar like the earlier thalassemia sometimes. So it can be so depends on the level of pain. So they can use non-opioid ones. If not, then you have to slowly escalate them up, right? So there's different ways of monitoring or calculating the pain scale based on their age. So this is just a reminder that different scales can be used. Right, so there's also home therapy and also special situations, and also dental care, because sometimes if the person needs to go for some dental treatment, what should they do, right? So it should be initiated soon, right, and things like that. So monitoring, so annual bleeding rate, right, inhibitor screening, and so on. So to put everything into a nice flow chart, so this is how is it. So if it's active bleeding, what should we do? So these are the things that we should do. Subacute, so we try to reduce the bleeding as much as we can. So, and also post-operatively, what should we do? Right, and things so on and so forth. Right, so details you can read through the guideline. Right, so there's another type of anemia, so which is called pernicious anemia. So this is actually mainly linked to vitamin B12. So when we look at the chart here, so as you can see, so we focus on the center first. So it's from the diet, right? So what happens after you eat? So obviously it travels down the GI tract. So what happens is that there'll be some activity mainly in the stomach, right? So what happens is that there is something called intrinsic factor IF over here, which can actually bind to the vitamin B12 and then to go down the lane, right? And then therefore there's proteases and then it goes along. And then if you can look at the small intestine, you realize that it needs to be absorbed together, right? So this is the CBL, it's actually cobalamin, right? So which is vitamin B12, the other name for cobalamin. Right, so you can see it's so to enable good absorption or allow absorption of vitamin B12 or cobalamin, you need the presence of intrinsic factor, which is available in the stomach. So the binding occurs and then it travels all the way down for its absorption. So what happens is that you can see what are the causes. So you can see if there's a reduction or removal of this section, there's no intrinsic factor or reduced, so you can the person can experience pernicious anemia, right? So sometimes it can be due to some autoimmune disease that destroys the parietal cells and therefore overall causes a reduced intrinsic factor as well. So another part is, so here this is just a short case to show. I managed to find a short one, so I just put it here. So it can be, the person might experience fatigue, pins and needles sensation, poor concentration. So pallor, so meaning pale, right? Resting tachycardia and so on. So the main diagnosis is from the blood smear. As you can see, it has macrocytic anemia and also hypersegmented neutrophils. So further investigation then show this is pernicious anemia. So common features as mentioned over here is like any other anemia symptoms, right? So there are some red flags that you need to be careful for the complications. So it can actually cause, if there's symptoms of depression and all, it can actually have a neuropsychotic manifestation. Shortness of breath and all can actually lead to cardiac failure, which is something you want to avoid, and also peripheral neuropathy, again, something you want to avoid, because all this will obviously reduce the mortality, increase the mortality, and also reduce the quality of life of the person. Okay, so next we'll go through what happened. So this is the diagnosis. So there's clinical features, certain red flags, and there's also macrocytic anemia. So you can check the cobalamin level. So and then to have a confirmed one. So and then check the intrinsic factor, and therefore to know that it is pernicious anemia or not. Right, so in such cases, you need actually supplementation of vitamin B12, right? So if there's no neurological symptoms, they can just have IM injection 3 times a week for 1 or 2 weeks, right? For 2 weeks, twice a week for 2 weeks, and then every 3 months. So if there's neurological symptoms, so it's something which is more severe, so you have to have alternate day of IM injection until it has clinical improvement, right? And then further on, there's the maintenance dose every 2 months. So cyanocobalamin, so information from the MIMS, as you can see here. So if it's a confirmed diagnosis, so it has to be, you have to provide it, right? So basically the details of it is actually in the hematopoiesis process. So it's converted to coenzyme B12 and then converted to methylmalonate, right? And the whole downstream of it in the folic acid pathway, right? So therefore, you need it to make sure the system works properly, right? For the synthesis of DNA, right? So over here, you can see that it's available in IM or oral form. So IM as mentioned earlier on. So you can see that if the person, so give it a scenario, if the person is actually had some stomach surgery, for example, that there's a reduction in intrinsic factor, can you actually use oral form? So maybe it may not be the best way, isn't it? Because you need intrinsic factors to bind to it. So therefore, if there's no intrinsic factors, no matter how much vitamin B12 that you pumped in the system through the oral form, the absorption will still be minimal. So therefore, you still need to go through the IM way. All right? So again, as a reminder, because vitamin B12 can be available in food, so these are the natural sources of vitamin B12 from salmon, fish, mutton, dairy products, mushrooms, and also it's available in the veggie part like cauliflower, broccoli, and other fruits as well. Okay, so again, if the person is having a normal balanced diet, then things should be fine. Okay, so we'll move on to the next one, which is hemolytic anemia. So there's actually quite a lot of subtypes over here. So I'll just go through bits and pieces of it. Right, so it most of the time is actually as an autoimmune disease base, right? So sometimes it can be secondary issues. So you have to check whether because there can be primary or secondary ones. As you can see, sorry, this is a guideline, but I couldn't get the very pretty PDF version, so it's the crumpled up Word PDF version. Sorry for the background sound. So basically, it's an anemia due to a reduction in the RBC lifespan due to increase in destruction. So there's more destruction than formation. So it can be due to an autoimmune base, right, which refers to the title AIHA, right? So they can be autoantibodies, no idea how on earth it occur, right? So it can be very severe ones, so depends on the level of the hemoglobin, how reduced it is. So they can be the secondary one rather than the primary form. So one of the cause of the secondary can be due to exposure of certain drugs. There's actually a whole list of it in the guideline, but these are the ones which are probably more commonly found, as pointed out, like antibiotics, diclofenac. So surprisingly, some are actually quite common drugs. Oxaliplatin and others will be more on the oncological based drugs. Okay, so let's have a look. Okay, so again, you have to actually, besides doing all the tests required, they actually have to consider the relapse risk as well and the clinical severity. So next we look at over here. So what happens is that we mainly want to treat the symptomatic ones. If it's non-symptomatic, you can sort of leave it in a way. So if it's symptomatic, you can actually, because it's mainly autoimmune disease in nature, so it's basically a steroidal based treatment. So it's a prednisolone, and or with rituximab, right? So prednisolone is about 2 to 3 weeks, and then you taper accordingly, right? If it still doesn't work very well, so you probably have to use a second line drug, so you can use rituximab again, depends on whether you use it at the start or not. So you can actually probably use other immunological based disease, right, like azathioprine, cyclosporine. If not, then it's still then a third line like cyclophosphamide and things like that. So it's very different way of treatment compared to other anemia. So again, depends on the cause of it, isn't it? So next, so there's different types of it. So this is one of the rare form, which is co-agglutinin mediated. So this is just to show you these are the things which are available, right? Which you can find clinically, right? So so basically again, what should I point out? So again, you can see rituximab here as well, right, and some trials on clinical drugs and things like that. So this is one of the costs that that's being pointed out in the guidelines. So there's a cold agglutinin disease and also cold agglutinin syndrome over here. Okay, so there's certain antibodies which are available based on for their criteria of diagnosis. Right, so if we move on to another type of anemia, which is called aplastic anemia. Right, so aplastic anemia is most of the cases idiopathic, so in a way we don't really know what happened, but we try to take a clear drug history as possible. So when you look at the changes in the blood count, this is something which is more general as mentioned, so it can affect different types of blood cells. You can see it can be pancytopenia, so the hemoglobin levels are depressed, and also the neutrophil and platelet counts as well. So it's a multiple one, right? So it can be reticulocytopenia as well, right? And there's also some macrocytosis and things like that. Okay, so again, the person will be presented. So as you check the age of the person, so is there what should we do if there's a donor, in case, so we probably have to consider it. So refractory, so you actually have to match with a donor if it's a very severe type, right? If it's not, so you can actually use drugs to treat it. So repeat course of IST here actually refers to ATG, which you actually need to use anti-thymocyte globulin, so the short form over here, and CSA is cyclosporine. So this is for this aplastic anemia, so this is the two main drugs which you need to use. Okay, so it also appears here as well, right? So this is the first line, right? So there can be other experimental therapy which is yet to be explored. Right, so again, this is aplastic. It could be due to any radiation-based exposure or toxic ones, or sometimes we don't even know what on earth suddenly happened. Okay, so next, so this is the last one. So this is just a recap on leukemia, which is a summary which can be found in the that I just extracted from the anatomy and physiology textbook. Okay, so that's all for the class on hematological disease. Okay, thank you.